Okay, hello and welcome. This is Dan Swiskers from wemonline.net. In today's session, we will continue talking about upper back region and shoulder region. Last time we talked about rhomboids, rhomboid minor, rhomboid major, and trapezius. That's right, and I think that's where he stopped. So today we will review the anatomy one more time. So we will take a look at bony landmarks. Once again, attachment points, right? So origin, insertion, and function. This is the purpose of these sessions, really. And then we will talk about possible injuries of this particular structure, whatever that might be. Possible ways to prevent the injury, possible ways to treat the injury, possible ways to live with the injury if it's not really treatable. Sometimes, if it's a chronic condition, like let's say some type of laxity, for example, shoulder problem, right? It's just popping out again and again and again. So there are ways to live with that. So you could increase actually your productivity. You can increase your mobility, your function, and you're not actually going downwards into that downward slope, because usually with these chronic conditions, so you have to be very, very careful not to injure it more, so it doesn't get worse. But if you're not really using it enough, that's another problem. So you have to be kind of like right in the middle. Use it or lose it, right? You have to still use those muscles, use that joint, whatever that is. As well, you shouldn't overuse it to prevent further injuries, further damage. So, and this is this type of perspective we are using. We are looking at all these structures from this type of perspective, more sports-related injuries. That's the main topic, basically. So let's switch to the screen. Let's start with the three-dimensional human. I think it's better to do it that way. Okay, here we go. All right, so here we can see our three-dimensional body. It's all in X-ray. Last time, so these are actually all the muscles that we talked about so far. Okay, right there. So you should already know some of these guys, right? So here we have pectorals. That's pectoralis major. We talked about that not last time, before last time, I think. We will review pectorals today one more time. So we will add pectoralis minor, and we will review pectoralis major once again. So pectoralis minor should be right underneath, right there. That's where it is. Sorry. Yes, there. So yeah, so that's pectoralis minor. We will take a look at this muscle today. As well, probably we might look at some of these structures once again, one more time. We talked about deltoid. We spent quite a bit of time on that. Maybe we'll just do a quick review on deltoid. Sits muscles, we'll not talk about sits muscles today, but here you can see them very nicely. So this is subscapularis. That's the only muscle that is attaching on the humerus from anterior side, so from the front. And that makes it internal rotator. So that's one of the sits muscles, and here we have three other sits muscles right there. So supraspinatus, infraspinatus, and teres minor. So now all of them are highlighted. Actually, let's zoom in a bit. So this is just a quick review. We talked about that. We spent quite a bit of time on sits muscles, but it's always good to do a quick review, so just to see where exactly they're at. So once again, here we can see subscapularis. wrapping around humerus from the anterior side, and then 3 other sits muscles surrounding, kind of wrapping around humerus, humeral neck, humeral head from the back, from posterior side. These two right there, infraspinatus and teres minor, they will be able to do external rotation. The supraspinatus, this guy here, is not going to be able to do external rotation because it is attaching on the humerus, kind of like on a superior, right at the top. So that's not really the right angle for it to be able to actually produce some sort of rotational movement on the bone. So these are sits muscles as well. We can see the joint capsule right there. That's the also, so to say, like, really, I think we talked about that as well. These are so-called ligaments, right? So coracohumeral ligament, glenohumeral ligament, but really they are sort of like a thickened areas of the capsule. All these ligaments are basically just thickenings of the capsule. You would be able to see it very well if you look at dissected body. You know, like when you actually use a live cadaver, you dissect the skin, everything. You like unfold all the muscles, and when you look at the glenohumeral capsule, you see that all those ligaments, you know, like there's no really transition line between them. They're basically sort of like just thickened areas in the capsule, right? So, but here this model shows them nice and separate, separated. In real cadaver, it doesn't really look like that. Last time we talked about trapezius, right there. We'll probably do a quick review on trapezius once more today. Let's go a layer down. Rhomboids, and this is probably where we stopped. So rhomboid minor, rhomboid major, rhomboideus minor, rhomboideus major, that's in Latin. And that's where we stopped last time. So today we will take a look at levator scapula. That's another muscle in the region. So as the name states, basically it refers to elevation of the scapula, and you can see where it attaches. Obviously, it's going to lift the scapula up towards the ceiling if the fibers contract. As well, we will look into pectorals, as I said. So pectorals minor, pectorals major once again, and let's see how much time we have. Maybe we'll add another one. So, but I think most likely we'll probably go with the levator scapula, pectorals minor, pectorals major, and that's probably going to be enough for today. Maybe serratus anterior, that's another one. So maximum 4 muscles today. Let's start with the attachment points. So bony landmarks. That's quite important. We need to be able to figure out the attachments, right? So once again, let's start with the with this drawing here. I think we did the same everything last time. Okay, this one's pretty good. All right, actually, no, this one's better right there. Okay, all right. So last time we did already review some of these structures. We'll go over this one more time. So here we can see scapula. Or so to say, shoulder blade, right? So what structure should we know on this structure here? What structure should we know on the on this bone? So here we can see spine of the scapula. That's spine, easily palpable. Everybody can find that with ease. Spine of the scapula. And then we can then we can distinguish. Actually, no. Like let's go with the fosses. So superior fossa and inferior fossa. That once again, this is just a quick review. Superior fossa, just the bow spine of the scapula. So this part here, right there. Superior fossa is where the supraspinatus originates from. So that's this part is going to be occupied by supraspinatus muscle. Superior fossa. Inferior fossa. That's where the intraspinatus originates from, and well, we can sort of say that teres minor, teres major originate from. I mean, not really. They kind of they will have some fibers attaching to inferior fossa, probably. I mean, through intraspinatus, really, but indirectly they will be connected to inferior fossa as well. So inferior fossa. Then some other landmarks. Let's talk about angles. So once again, directions. Superior, that's going towards the ceiling. That's up. Inferior going downwards, towards the floor. And then towards the front, towards the back, towards the front anterior, towards the back posterior. So these are basic directions. And then closer towards the center and away from the center, that's medial and lateral. So this would be so let's say like the spine. That's the center of the body, right? That's the axis. So closer towards the center, that's medial direction. Away from the center, that's lateral. You should know all this by now, but this is just a quick review. So angles, knowing these terms, you should be able to figure it out on your own, really. I mean, like, what angle is this right there? That's inferior angle, obviously, because it is pointing downwards. It is pointing towards the floor. So this angle is going to be named inferior angle. Inferior angle of the scapula. This angle here, just right at the root of the spine of the scapula. That's medial angle, obviously, because it is pointing towards the center. So this is medial angle. And then this one, obviously, is going to be superior angle, pointing towards the ceiling, right? Superior angle. Oh, sorry. And that's it. So there's no lateral angle. But there is lateral border and medial border. And again, well, obviously, what would that be? I mean, that refers to this edge here. This edge is pointing towards the side, away from the center. So this is obviously going to be lateral border of the scapula, and this is going to be medial border, right? Again, pointing towards the center, so medial border. And let's right there. It's the same, right? So medial right there, medial border, and that's about it. So well, obviously there are many more landmarks on the scapula, but we're not going to get into that right now. We don't really need to know everything right now. We're just talking about these particular landmarks that we need to know to be able to talk about muscular attachments, and in particular these muscles that we are going to talk about today. So we'll talk about we'll do a quick review on the rhomboids. So where did the rhomboids attach? They did attach on the spinous process. Let's use a different color. Spinous processes, right? Spinous processes of the spine, and basically medial border, right? Medial border of the scapula. So that's where the rhomboids are. They occupy this space. Rhomboid muscles. There was rhomboid minor, rhomboid major. The pectoralis major, pectoralis minor, those muscles are from the front. Subscapularis from the front. Serratus anterior, that's one muscle that I wanted to talk about today. It is going to attach on the medial border, just from the front. Okay, so let's use a different color. You know, that's quite nice right there. So the medial border, but from the other side. So we are looking at the back right now. If we would turn it around, let's turn it around. Okay, right there. So this is anteriolateral view, okay? So because we are looking at the front and at the side as well. So proper name for this view would be anteriolateral. Anteriolateral view. So serratus anterior is going to occupy this space here. So it's going to come off of the medial border on the scapula, right there. And it is going to wrap around the rib cage, kind of like that. And it is going to attach on the ribs. We'll see that in a bit. And what does serratus anterior really mean? I mean, like, again, we had to look at the name. What does the name say? Serratus. That means serrated structure, like a saw. Okay, so saw like basically muscle that looks like a saw. Saw, you know, saw, like, you know, cutting wood, right? So that type of stuff. You know what I'm talking about, right there. Oh, here we go. Very good. So serrated muscle, and it is going to interlock with the one of the abdominal muscles, right? So that's one of the oblique muscles. We should remember this. We talked about that at the beginning, one of the first lectures. So it is going to interlock with another muscle at kind of like at the side of the body. We'll see that in a bit. What else we need? We need. So hang on. Let me take a look at this one more time. So levator scapula, serratus anterior, pectoralis major, pectoralis minor. These muscles are. We'll talk about these muscles today. Levator scapula. Yes, I think we're good. I think we can start. No, one more structure. Okay, and actually we can see it right there. So in scapula, here we can see. So this is scapula. This is part of the scapula, okay? And this is part of the scapula. Right there. That's the whole shoulder blade. This, as we already know, this is called the acromion process. And this structure right here, this is like quite a few muscles will attach to that. This one right there. That's coracoid process. So this is a new structure. Probably you didn't know about this one yet. You should memorize this one. That's quite significant, important landmark. And then of course we have clavicle. We have let's quickly color the other ones. How about brown, something like that. Good. So clavicle. Clavicle we can divide in. Usually we will divide clavicle in 3 parts, because majority of the muscles are going to attach either to lateral end or to medial end, or a lot on lateral end, but spanning out a little bit more than. So not exactly half, but a little bit more than a half, and vice versa. So every single structure in our body we can divide either in 2 parts or in 3 parts. Again, we already talked about that. That's a little bit of review as well. So clavicle usually we will divide in 3/3, right? So 3/3. So 1/3, 1/3, and 1/3. So, and obviously, so this is going to be, this third here is going to be lateral 1/3 of the clavicle. This third here is going to be medial 1/3, because it's closer to the center. And this 1/3 here is going to be middle 1/3. Don't confuse this with medial. Middle and medial are not the same. This is that's very common mistake. First, when somebody starts learning about anatomy, it can get a little confusing. It's a little bit like a similar words, right? But really pay attention what you're saying. We really pay attention to what you're reading. Really pay attention to what you're saying. Medial and middle. Completely different words. They refer to different regions entirely. Medial meaning closer towards the center, and middle something in between. So we have, like, let's say left side, right side, and right in the middle, right there, right in the middle. And then medial, that's, you know, as we talked about it just a moment ago, medial and lateral. Lateral meaning away from the body, medial meaning closer towards the midline, right? So don't confuse this. You will see this a lot in all different kinds of literature. So for example, like origins or insertions, bony landmarks, there's going to be like medial, like let's say medial 1/3 of the clavicle, or middle 1/3 of the clavicle. Those are completely different parts, right? So let's take a look at the clavicle one more time. So this is right there. This is medial 1/3 of the clavicle, and this is middle 1/3 of the clavicle. Middle, and this is lateral, right? So this is lateral 1/3 of the clavicle. Yes, and then we have sternum, obviously. So sternum is divided into 3 parts. This right there is manubrium. Well, okay, let's name it manubrium. This is the body. Body of the sternum, right? body. And this little nibble here, this little guy at the end here is called xiphoid process. And then of course we have ribs and we have humerus, right? So in this region, really, that's we're talking about muscular attachments like shoulder girdle muscles and upper back muscles. Really, we just need to know rib cage. That of course we have ribs. We have sternum, 3 parts of the sternum, superior part manubrium, middle part, the biggest part, body, lowest part, inferior part, xiphoid process, clavicle, which we can divide in 3 parts, lateral third, middle third, and medial third, scapula, very significant feature here, acromion process of the scapula, and coracoid process of the scapula. And then, of course, here we can see anterior surface of the scapula because it is pointing towards the front, and on the other side, posterior surface, which we discussed earlier. Right there, that's the posterior surface. And on posterior surface, we have superior fossa, inferior fossa, spine of the scapula, right there. Maybe a different color. Okay, blue is going to be good, right there. Spine of the scapula. This portion here, right at the medial angle, is called the root. Like, trees have roots. Root of the scapula. And then the angles and the borders, basically, right? So superior angle, inferior angle, medial border, lateral border. And that's about it, really. So you should be able to remember at least these structures. And then the spine, right? And then the spine and back of the head. So as we discussed that last time, so at least you should know these structures. At least you should know spinous processes. Right there, spinous processes. Those pointy outgrowth. So the vertebral column, like a vertebrae. The ones that are pointing side to side are called transverse processes. So transverse processes of the T-spine, so that's middle of the vertebral column, and they will mostly serve function basically just to connect the spine to the ribs, really. So that's the main connection, really. Main function of the transverse processes, and then right in between. They call this space is going to be occupied by muscles, primarily deep back muscles, so multifidus, some other deep muscles, and right on top, like more superficial layers, that's going to be erectospinae group, right? So this lamina groove is going to be occupied by muscles, right? Back of the head, very significant feature is the very significant feature is external occipital protuberance. Very, very, very important. And here we can see the nuchal lines right there. This is quite good. These are a couple of the other structures that we should know. Let's start with the easier ones. Nuchal ligament, right there. You see, it's even on this image, you can see it's quite broad, quite thick. You know, it's very tough, thick structure. A lot of muscles will attach to it, and you can actually palpate it. You can feel it when you go with your fingers, can like right between your back of the head, right between kind of right where the head ends, and right above shoulder line. Just run your fingers back and forth in this region, back and forth, and you'll feel it. You'll feel that. Just bend your head downwards a bit, and go with your fingers back and forth, side to side, and you'll be able to feel that that stiff, thick tendon, like a tendon or ligament. That is called nuchal ligament. Let's use black. Nuchal ligament. Right there, this little bump here, you can actually see that even in this image, it looks like a little heel here. Another very easily palpable bony landmark. It's one of the easiest to palpate, actually. This is called external occipital protuberance, or in short, just EOP. EOP. External occipital protuberance. EOP in short. And we can also see nuchal lines, superior inferior nuchal lines right there. Again, those, you know, maybe, well, at first it takes a little bit of practice, but these ridges you can actually feel as well. So if you go with your fingers this time, not transversely, not side to side, but this time up and down, like this, up and down. Just run your fingers up and down, and you'll be able to feel like a ridge, like a little bump. And the one above is called superior, obviously, and the one below is called inferior nuchal line. So superior nuchal line and inferior nuchal line. And inferior nuchal line. And I think we're good. These are all the structures that we need to know so far. Talking interscapular area muscles, more superficial layer, right? I mean, we're not really talking about deeper structures right now. We're really just talking about the major muscles between shoulder blades. Between the skull and shoulder level, and muscles that surround the shoulder joint. So the biggest of them, the most significant of them, you can talk about anatomy. You can discuss their anatomy if you know these structures. So it shouldn't be a problem if you know these structures. Okay, so and I think we're good. I think we can start. Let's turn my video back on. Let's have a quick chat, and we'll start with the first muscle. Okay, turn your mics on, and let's have a quick chat.
Yes.
So far so good. So everything understandable?
Yeah.
Yeah, more or less, yes.
Yeah, these structures you should memorize. I mean, you know, but it's like the easiest way, really. Like my biggest suggestion is, once again, I mean, it really depends how deep, how in depth you want to go with this. How serious are you about anatomy? My biggest suggestion would be every time when you learn some new structure, try to palpate it if possible. It's going to be way easier to memorize it. So like all this, like an external, you know, so nuchal lines, superior inferior nuchal lines, EOP, external occipital protuberance, spinous processes, transverse processes. You're not going to be able to feel. Well, you know, very skilled professional. So I mean, I actually can feel transverse processes like on the neck at least, and a lumbar spine. It takes very, very, very fine skill to feel those structures. But in neck region, you will be able to feel transverse processes. At the back, not really, because they're quite deep underneath. They're hiding under all the muscular layers, and they connect directly to the ribs. So they're really transversely. Transverse direction, so you cannot really feel it. Actually, you can feel the joint a little bit right in between transverse process and the rib. You can feel that joint a little bit. But anyways, you know, like, so I mean, any structure that's palpable, any structure that is at least somewhat palpable, or even if it's not palpable, just put your hand where it is, just kind of, or just like, I mean, try to imagine, okay, it's kind of there, right? So like transverse process, it goes side to side, you know, wrap your arm around your, you know, trunk and try to feel it at least, or whatever. It's going to be way easier to memorize it. So once again, what structure do we talk about? Can you recall them? So we talked about scapula, we talked about spine, we talked about back of the skull. Primarily, but we didn't really talk about humerus this time. Can you name those structures one more time?
Scapula, clavicula, spine, and
Yes.
the neck and backbone.
Neck. So yes. So okay. All right. So let's start with scapula. Okay. So scapula is like it's like a triangular shape, right? So this is kind of how it looks like right there. So it has 2 borders and 3 angles. So 2 borders, 3 angles. Can you name 3 angles?
Inferior, superior, medial.
Yeah. So inferior pointing downwards, medial pointing. So midline right there. No, my nose. That's the spine. So medial, not middle, medial. That's what I said. I think Edgar said middle.
I said medial.
Yeah, medial. Yeah, it's very easy to confuse that. I mean, maybe I misheard, but sometimes you think one, but you say the other. Be very careful with middle and medial. Very important, very important. So medial angle, angle pointing towards the center, and then superior angle, right? So we have 3 angles: superior angle, medial. So like we're talking about this side, right? So this is my right hand, this is my left hand. Right side scapula. Right side scapula should be located kind of like right there. So medial angle, superior angle, and inferior angle. Then we have 2 borders, one on this side, one on the other side. What are those?
Medial, lateral.
Lateral going away, medial going closer. Both of you guys want to talk at the same time, so I'll question you a little bit. Okay, let's spend like 5 to 10 minutes, but I will just ask. Okay, like say Edgar's answers or Ul's answers. Okay, because both of you guys want to say at the same time, and then there's a little bit, you know. Okay, so next question. So clavicle. Okay, clavicle, because most commonly we'll divide it in 3 parts. So Uldis, please. What are those parts? So that's right.
1/3. Yeah. Lateral, middle, medial. 1/3 of the clavicle. So.
Yes, very good, very good. Another another way to say it is in scientific literature, sometimes you will see that they say not medial or lateral 1/3 or medial or lateral end. It's correct. It is correct to say, like, let's say medial end of the clavicle or lateral.
Distal or
Distal, no. Distal is more distal. Proximal is going to be about upper limbs, lower limbs. This is still this is part of the trunk. So everything that's part of the trunk, distal and proximal doesn't really work. You can say it. You can say it, but it's not a very good way to say it. It would be correct, but it's not the best way to say it. In literature, sometimes you will see sternal end of the clavicle and acromial end of the clavicle. Okay, sternal end because this is the attachment. This is sternoclavicular joint between sternum and clavicle. That's the attachment point of your upper limb to your axial skeleton, right? So sternoclavicular joint. So this end is sometimes it is called sternal end of the clavicle, sternal end. So obviously pointing towards the sternum. So this is where it is, and acromial end. So acromioclavicular joint between clavicle and acromion process. Acromioclavicular joint. So this is called acromial end. So that makes sense, right? So that end that is closer to acromion is called acromial end, and that end that is closer to sternum is called sternal end. So that's another way. So okay, so that's very good. So we have clavicle. Most commonly is going to be divided in 3 parts. So medial 1/3 of the clavicle, middle 1/3 of the clavicle, and lateral 1/3 of the clavicle. Very good. So this will have to use. We will have to use it just in a moment. Talking about pectoral muscles, you will see that in a bit. Then sternum. Okay, sternum is divided in 3 parts. Edgars, what are those parts?
Well, the upper part was manubrium or something like this. Then the body, the major part in the middle, and the hyphoid process at the bottom.
Very good. Yeah. So 3 parts. Very good. That was very good. So upper part manubrium. It has this notch right in between the clavicles, both clavicular heads. Again, you can feel that. This is, I'm telling you, like I'm strongly encourage you guys, like right now, just feel it. Go with your fingers right there. Feel the clavicle where it ends. Feel that sternoclavicular joint on one side, sternoclavicular joint on the other side. You can easily feel it. You move your shoulder a little bit, and you will feel exactly where that joint is. So joint on one side, joint on the other side. Right in between, there's like a little hole. That is called sternal notch. Sternal notch. I will write that down in a bit. So that's another structure I didn't really talk about when I was writing all the structures down. So manubrium, the most significant feature is right on top. There's like a little indentation right in between both clavicles. This is called, once again, this is called sternal notch. Right there. So you can easily feel it. It's like a little hole there. And bone on one side, bone on the other side, sternal notch. Okay, so manubrium on top, sternal body in the middle. That's the biggest part. And xiphoid process at the bottom. Xiphoid process, you can feel it. Go right in between ribs. So ribs end here, right in between. So it's like a triangle. Where the triangle ends. Some people have the xiphoid process pointing towards the front. Some people have the xiphoid process pointing inwards. And this actually you can move it a little bit. You can, when you palpate it, you can move it around a little bit. It's not very pleasant spot, but you know it's again, you know, it is palpable. So very good. So we have clavicle, we have sternum. 3 parts on sternum, 3 parts on clavicle, clavicular. So the sternoclavicular joint from the clavicle side. On clavicle, you can say that sternal end of the clavicle is gonna articulate with the sternum, with the manubrium of the sternum, and we can say that acromial end of the clavicle is gonna articulate with the shoulder blade, with the scapula, with the acromion, right? Very good. So ribs. Ribs. I mean, let's not get into ribs right now. They're just a little bit too much. Just know that ribs cup your rib cage around. So like they come from the back. They will have joints between the ribs and the vertebrae. 3 joints. Typical on typical ribs, right? We'll have 3 joints that will articulate with the vertebrae from the back, and then we'll have joints articulating with the sternum from the front. And again, not all ribs are going to be the same. And I have some videos on that, some of the earlier videos, so you can probably look it up later. I'm talking about typical ribs, atypical ribs, vertebrae, thoracic vertebrae, typical thoracic vertebrae, and what is what. So those videos explain it all. So
maybe you can put the link in the chat afterwards.
Yeah, I'll give a link. Sure. It's in those, like, so far I think I have like 16 videos. So just like some of the first videos. I did talk about vertebral column, and in particular I was spending quite a bit of time on thoracic region, so that's a good review for you, and then you will know like what exactly is happening there. We'll go a little bit more into detail in next lectures when we will talk about core muscles once again, like multifidi, and a little bit like the deeper layers of the back muscles. There you will have to have a little bit better understanding about the vertebral column, about thoracic vertebrae, about cervical vertebrae, lumbar vertebrae, about all those processes, what is connecting with what. It is going to get a little bit more complicated. Today we are just, very more superficial structures, right? So that's why we are not going to really look into ribs right now too much. Okay, so clavicle, sternum, scapula, and then the neck and the head. Okay, so question for all this. So I named 3 structures on the neck region and back of the head. Can you remember them? What is what, and what were the names?
I actually don't remember. I just know I can palpate them. No.
Yeah. So this one. Remember this one, the external occipital protuberance.
Yeah, external occipital.
Right in the middle, that bump.
Yeah, I can hear it. Yeah, of course.
Yeah, EOP, very important structure, external occipital protuberance. Okay, so that's the most significant, actually, feature of the back of the skull. Then we have 2 lines. Can you remember those lines? 2 on one side, 2 on the other side.
Yeah.
What were the names?
I don't remember.
Edgar's?
Nuchal lines.
Nuchal lines, yeah. Superior nuchal line, inferior nuchal line. They are parallel, right? So two on top, two just slightly below, right? Superior nuchal lines, obviously, the ones on the top. Inferior nuchal lines, the ones that are at the back, and all these structures are found on occipital bone, right? So skull is not just one bone. So skull is, many bones, right? So and they actually articulate with each other. They have slightly movable joints. You can actually play with that a little bit. There's special technique. For cerebrospinal fluid, sometimes the cerebrospinal fluid, like the rhythm is off, and there are very specific techniques where you press on one bone or the other bone. I know that whole theory. It's quite interesting. But most of the people think that skull is more or less in one piece. Not at all. You can actually move those bones. They're just slightly, but they're movable, right? So they have slight movement in between, right? This bone we're talking about, occipital bone. I'll show that in a bit. What exactly I mean by that? It's just the back of the skull, right? So all these structures are found on occipital bone. So external occipital. That's what the name says. So external meaning on external, on the outer surface. Occipital, that's occiput, right? Occipital protuberance. Protuberance meaning a bump. So basically, to translate that name, it says structure that is found externally on outer surface, which is found on occiput, occipital bone. So occipital protuberance. Hill. Protuberance is like a hill. So basically what that is, it's a structure that is found on the outer side of the occipital bone that looks like a hill. That's what the name really says, external occipital protuberance. And then we have a nuchal ligament, right? So nuchal ligament, again, you can feel that, especially when you bend your head down a bit, when you run your fingers across like this. So you can feel it, right? It's very tough ligament. A lot of structures will attach to that ligament. You will see that in a bit. Okay, good. Let's take a look at the first muscle. Let's take a look at levator scapula, and then you can turn your mics off, and I'll talk for a moment. It's gonna be a little bit of monologue now. Okay, all right. So just to show you right there, here you can see this is occiput, right? This is occipital bone. That's just what I was talking about just a moment ago. Right there, this is occipital bone. That's not a good color. Okay, right there. That's one of the bones that make up the skull. Right there, that's occipital bone. So in all these structures that we were talking about, they are found on occipital bone. So superior nuchal line, inferior nuchal line, external occipital protuberance. And then as we go lower, nuchal ligament, which is attaching to occipital bone, but it is also attaching to spinous processes of the cervical spine and first thoracic vertebrae. So it's kind of like it's spanning out like that. Okay, that's good enough. So first muscle is the levator scapula, which is like actually, let's use this image for a moment here. Levator scapula, as the name states, is muscle that elevates the scapula, right? So levator scapula, like elevator, like levator scapula, which is gonna basically connect this point here to this point here. It's gonna kind of go up like that. And obviously we can see that, like these muscle fibers shorten. It's gonna pull on the scapula. Scapula goes up. Scapula goes closer towards the ceiling. Okay, let's take a look at it. And here we have it, right there. See, the interesting thing is you can see this quite well right now, that the fibers twist. Okay, the fibers. Okay, how can I show this? Okay, like this. Hopefully that's more or less understandable. That's what the fibers do right there. So there's a twist. You can see that. See here? It twists like that, right? And this is why this muscle is particularly prone for trigger points. Trigger points. What are trigger points? What is a trigger point? We'll talk about that in a bit. Okay, this is that's another lecture. That's talking about trigger points. That's probably another 3 hours just to discuss this subject. But I'll give a couple of quick examples what that is and what we do about it. So levator scapula. Let's take a look at the attachments. Let's use Nikita Vizhnek's image first. It's gonna be easier to right there. If that's in case you want to write it down. So once again, origin red, insertion blue, action green. Okay, and everything else I usually go purple. You like if you are taking notes, use these colors. Like I strongly recommend you doing that because it's just gonna be easier to remember first of all, and if you group everything in colors, you'll make like a system. It's gonna be easier to recall. It's gonna be easier to group these structures in your head. And so transverse processes of cervical spine C1 to C4, and here you can see it in the picture that they attach on the side, right? So these are the transverse processes. You can see that they look quite different from the thoracic rib cage. See, like in the thoracic rib cage, transverse processes, they point outwards way more than cervical spine transverse processes. So this is thoracic spine. They go outwards way more than cervical spine. For one reason, in particular, that there are no roots going through these channels. So, and there are no ribs here, right? So there's no need for these processes to be longer. These processes need to be longer because they articulate with the ribs. So it's all about function. It's all about function. So in the levator scapula muscle originates, once again, origin is going to be least movable point. That's the more point that will move less. Insertion is going to be the point that moves more. So, and obviously this, as the name states, this muscle is elevating scapula. So scapula is going up towards the ceiling. That's why this point here, this attachment point, is going to be insertion. This is where the muscle inserts. Originates from transverse processes. Basically, four transverse processes of the at the beginning of the cervical spine. So four transverse processes at the top, right? So like first, second, third, fourth. C1 to C4. And inserts into the medial border of the scapula. Medial, right? Medial border of the scapula. Superior part, right? So this is quite significant. Superior part. Superior part is right, and we can. There are many ways to say it anatomically correct. Okay, so this is as we already learned. This is the root of the spine of the scapula. This is the root. We can say that the muscle inserts into medial border. If you want to be really specific, okay, so we can say that muscle inserts at the medial border of the scapula between the root of the spine, the root of the spine of the scapula and the superior angle of the scapula. That's, I mean, you know, like that's as specific as it gets. But as Wisniak suggests, we can just say superior part of the medial border of the scapula. And that's, I mean, that's good enough. You know, it's understandable. So superior part of the medial border, so upper part, but it's kind of vague. It's not specific enough. I would say it's right in between root of the spine of the scapula and superior angle of the scapula at the medial border of the scapula. So that's very, very specific. So once again, it originates from transverse processes C1 to C4. So for highest, for upper transverse processes of the cervical spine, and it inserts into the medial border or the scapula between the root of the scapula and superior angle of the scapula. Action. So what does it do? It elevates the scapula, and that's the main action. As you can see it here, elevation of the scapula. As well, and this is again, this is the scenario where scapula doesn't move. Okay, so scapula is in fixated position. It's in scapula doesn't move. So let's say this is immobile. When we hold the shoulder blade so it doesn't move, when we shorten the fibers, it will actually extend and laterally flex the neck. Okay, so let's talk about this a little bit more in detail. You can turn your mics on. So levator scapula, right at the top of the shoulder blade, inserting at the transverse processes of the cervical spine, top 4 cervical vertebrae on the side, basically, right? Primary function, elevation of the shoulder blade, right? So right there, one side or the other side. So we flex right sides, levator scapula going towards the ceiling, left sides shorten left side fibers, left side scapula going closer towards the ceiling. What if we fixate? So shoulder blades don't move. We fire both of them, okay, which is bilateral. Okay, so bilateral, to be anatomically 100% correct, we have to say bilateral contraction of levator scapula muscle, meaning both sides muscles contract. That will create extension, obviously, right? We are tilting the head backwards. What if one side shortens? That's going to be ipsilateral, first of all, right? So ipsilateral contraction, meaning on one side, ipsilateral lateral flexion on the same side, okay? So ipsilateral flexion, meaning flexion towards the same side. Contralateral flexion would be flexion towards the other side. So we are shortening structure on this side, whatever that would be. So this side's muscle would produce the movement, but the head will actually turn away. That is contralateral flexion. Bilaterally, levator scapula is gonna extend the head, so movement towards the back, right? So both sides shorten. We tilt the head towards the back. One side, meaning unilateral contraction. It is gonna produce ipsilateral flexion of the cervical spine. Okay, so first of all, bilateral and unilateral. Bilateral meaning both sides contract, unilateral meaning one side contracts, and then ipsilateral and contralateral rotation or flexion. Is that understandable? So flexion towards the same side, flexion away from that same side. Rotation towards the same side, rotation away from that side. Ipsi, lateral, towards that side, contra, lateral, away from, like we rotate away from this side, and we flex away. So for flexion, we say ipsilateral or contralateral flexion. So that would be like we're talking about right side structure that's producing the movement. So it is gonna either ipsilaterally flex or contralaterally flex, or ipsilaterally rotate or contralaterally rotate. And then once again, we talked about bilateral or unilateral. Bilateral meaning both sides contract, unilateral contraction meaning one side contracts. So this has to be very understandable. We will talk about other structures more in depth, and that's why like last time I showed the example with rotation of the spine, because some structures will actually pull the spine towards the other side. Some structures will actually pull the spine towards the same side. So this has to be really clear. So some structures actually can move that, twist that part of the body away or towards the same side, or bend that body part towards the same side, or bend it away. So that has to be very understandable. Any questions on this?
No.
No?
You just remember.
Yeah, so once again, ipsilateral, contralateral, bilateral, unilateral. So unilateral contraction, bilateral contraction. Ipsilateral, rotation or flexion, rotation or flexion towards the same side. Contralateral, flexion or rotation or flexion away from that side. It will sink in. It's gonna be okay. Okay, you can turn your mics off. Let's go back to screen share. All right, so that's pretty much it. That's the levator scapula. Levator scapula is innervated by dorsal scapular nerve. Okay, dorsal scapular nerve originates from nerve roots C3, C4, C5. Dorsal scapular nerve. If you're able to remember, I mean, go for it. It's really good practice to remember nerve as well. I wouldn't really bother about like the artery and well, synergist said if you're able to visualize it three-dimensionally, like how everything, how the body works, there's not going to be a problem with synergist at all. So synergist. Agonist, antagonist, synergist, that's not going to be a problem at all. That you will be able to figure it out. Even if you don't know it, you will be able to figure it out. Blood supply, not the most important information. Nerve, sometimes it's good to know. I mean, especially if you are aiming to be some type of therapist, maybe sometime in the future. I mean, I don't know, like maybe going to physiotherapy or chiropractic or something like that, or just for yourself, just to know. It's really good to know nerve roots. That's more talking about dermatomes, myotomes. Maybe you have heard about that, what that is. Dermatome or myotome. What that is. What is that? So again, let's look at the name. What's dermatome? Derma, that refers to skin. Myo, that refers to muscle. So basically, what the dermatome or myotome is, it is either, like, let's say for example, skin. It is a skin patch of the skin innervated by that particular nerve. Okay, so like let's say for example, like I'm just giving a wild example. Okay, so let's say C2, C3. So this I'm just making this up. So like the C4 or C5 nerve roots are gonna innervate like one patch, like, or for example, like this patch, this particular patch on the skin. Okay, This is called the myotome. So this patch of the skin is innervated by these nerves, and it is called this is called dermatome. Sorry, dermatome. Myotome is basically the same thing, you know, but the myotome, obviously we're talking not about the skin, we're talking about muscles, right? So muscles. So for example, let's say the same nerve roots, C2, C3, C4, C5 are going to innervate, like let's say for example, you know, levators. Well, obviously in this case we can already see that C1 to C4. So C1, C4 is going to innervate levator scapula, for example, upper trapezius, deltoid, and so on and so forth. So that's myotome. Okay, so these muscles are innervated by these particular nerve roots. That's a myotome. Okay, so that's just an example. Why knowing nerves? Why would that be helpful for a therapist or for a practitioner? Sometimes, you know, like let's say for example, somebody comes in and says, okay, well, I have pain in this region. If you know dermatomes and myotomes, so if you know exactly what nerves are responsible for innervation of that region or like innervation of the skin. So for example, somebody says, well, I can't feel this patch of the skin, you know, like it is just sort of like numb, you know, like I can't feel hot or cold or anything. So usually there's going to be a problem with the nerves, and then we can figure out exactly what nerves are responsible for that. It is also going to be very helpful to distinguish between different conditions. So to be more clear, is this like a muscular problem, or is this nerve problem, or is this what is this, right? So knowing nerve roots, knowing nerve origins, knowing dermatomes and myotomes, it is going to be very, very helpful for, I mean, not for like a personal trainer. I mean, maybe, you know, like you always want to push the limits. You always want to know more. I mean, at least that's the way I look at it. Okay, so yes, so that's it for levator scapula. Trigger points. I talked about trigger points. So let me just give you an example. Trigger point for right there. Here we go. This is a trigger point pain referral for levator scapula. Okay. So this is very significant, actually. So this is levator scapula trigger point pain referral. Remember what I said about the anatomy, like the way it twists. It makes that turn. It's sort of like those fibers, they twist around. Okay. And because of that twist, it is particularly prone for trigger point. What is a trigger point? What's a trigger point? So basically, trigger point is an exquisite nodule. So somewhere in that muscle belly is going to be this really, really tight fiber that is just that's just like, let's zoom in. Okay. So somewhere in that muscle belly, there's going to be this one particular muscle fiber that's just working night or day. I mean, it's just like you sleep or you're doing whatever, it is contracting. It's just not letting go. It is in constant contraction mode. And then usually that muscle fiber will develop an exquisite nodule. It can be at the attachment point, okay? It can be right at the center. It can be pretty much anywhere, but like there's theory why and where they happen, and but I mean, let's not go into details. Just know that usually this tight muscle fiber band will develop like a point, and you're not going to be able to really palpate it, but when you will press on it, it is gonna create a very typical pain referral. And for this particular muscle, this is this pain referral. So let's say, for example, that's where the trigger point is. Let's use a different color. Let's use, for example, purple. Okay. So let's say this is the trigger point that is responsible for this. You press on it, and like that person feels this pain kind of going up the neck a bit and down the shoulder blade, kind of like right here. This is very typical pain referral pattern. I have seen this like, I don't know, hundreds of times in my practice. So it goes kind of like right down the shoulder a little bit, kind of like down the deltoids a little bit, and a little bit up the neck, kind of like right behind the ear almost, kind of like right there. And if you see this pattern, you know, they kind of like going up behind the ear, side of the neck, and going away, kind of lateral side of the scapula, going closer towards the deltoid. I mean, almost for certain you can say that that's levator scapula that's creating that. There are some other muscles in the region with similar trigger point pain referrals, but this is the most typical one. I mean, this is very typical for levator scapula to develop a trigger point, because those fibers do that 180-degree twist, right? And again, those are going to be those people that are, like, let's say, for example, under constant stress, just elevating shoulder blades, breathing apically, so not breathing with abdomen, breathing with the chest, with upper muscles, and this region is going to just get tighter and tighter and tighter and tighter, and basically you just develop sort of like that posture with just elevated shoulders, right? So this is not the only muscle that's going to be involved in this, but it's one of the key muscles for this, like, elevated shoulders and protracted shoulder posture. And with that, you can definitely expect trigger points. Trigger point, in short, we just go with this TRP, trigger point. So sometimes in literature you'll see this TRP. So that's a trigger point, okay? I think that's good for levator scapula. Let's move on. Let's do another one. Let's do serratus anterior, and then maybe we'll do pectoralis major. Maybe we won't. I mean, we don't have to rush this anyways. Okay, so here we can see serratus anterior. Very good image. Let's go to this guy here. That's a little bit better way to see it. See how it wraps around? Let's go X-ray. Right there. See where it starts? It starts from medial border of the scapula, just from the other side. Okay, so just from the front, and then it wraps around the side, wraps around the rib cage, and it will insert into the ribs. Okay. And just think about, like, just short. See, it has like 3 zones, right? So some fibers are going kind of like in superior direction, like almost 45-degree, going towards the side and towards the ceiling. Some fibers are going transversely, so parallel to the ground, and some fibers go kind of like 45-degree, going downwards. So obviously that's the direction. If we contract all fibers, what's going to happen? Scapula is going to be drawn towards the front, so you'll pull on shoulder blade and it's going to go towards the front. If you will pull on just the lower fibers, what's going to happen? You will lower the shoulder blade and you will actually tilt it backwards. Okay, I'll show all that in a bit. And what's going to happen if you shorten only upper fibers? You will sort of elevate the shoulder blade a little bit, and you will tilt it downwards, right? Let's go back to this image here, and I'll try to explain all that. Okay. Let's go to this. So once again, let's start with with the attachment points. Okay, so origin, insertion. Origin, where does it start? It starts from actually here, not from the scapula. Okay. Well, I mean, you can flip this around, obviously, right? You can say that this is the starting point and this is the end point, but usually we will talk about the least movable point being the origin, and more movable point being insertion. So it is acting primarily on the shoulder blade. That's why this is the starting point. This is considered as the starting point. So ribs 1 to 9, okay, lateral surface. So this is lateral view. So this is anterior. That's anterior direction. That's posterior direction. Right now we are looking at the lateral side, lateral. So and this is right there. So we can see ribs. So and it does attach. Let's use purple. It does attach, kind of like right at the middle portion of the ribs, outer surface of the ribs 1 to 9. Okay, and middle portion of the ribs is lateral. It is pointing laterally, right? It is pointing towards the side, right? So that's why we can say. So this is sort of like a summary of it all. Ribs 1 through 9, lateral surface in particular. Insertion, where does that insert? It does insert into the coastal surface of medial border. Okay, so this is that's something new, right? So what is coastal surface? It's the same. Really, it's interchangeable. You can also say anterior surface, and you'll be right. I mean, let me show it here. So here you can see that's the attachment, and and this muscle is attaching not at the back. Not from the back surface of the shoulder blade. It is attaching at the front surface of the shoulder blade, which can be called anterior surface because it is pointing towards the front. Okay, so this right there, this surface here, it is obviously pointing towards the front, or coastal surface because this surface is also pointing towards the ribs. And ribs in Latin, that's costatum, right? So coastal surface. So once again, it's interchangeable. So you can say either a coastal surface, coastal, or anterior. And you'll be right. Coastal, once again, what does coastal mean? Costatum. That's ribs. In Latin, right? So coastal, that refers to ribs. So basically, the surface that is located toward that's pointing towards the ribs, like that is facing ribs, right? Surface that's facing ribs. That would be probably the most correct way to say it. Action. Okay, so in this it is gonna get a little tricky here. So here Wisniewski states only main actions, but there are more than that, really, because if we can see clearly that some of these fibers are pointing downwards. Okay, some of these fibers are pointing. So like they are running kind of transverse. They are running parallel to the ground, and some of these fibers are going 45-degree angle up. Up, right, or down, or side to side. Okay, so if we fire all of them, if all, like the whole muscle works, obviously we'll protract. Protract. That's meaning scapula is going towards the front, right? We are pulling on the shoulder blade, and shoulder blade is moving towards the front. As well, we can say abduction, right? Because once again, what is abduction? AB, abduction. Abduction, that refers to something moving away from the center. And as we pull on the shoulder blade, obviously it is moving away from the center of the body, right? It is moving away from the spine. That's why we can say abduction. If we would be moving a shoulder blade backwards, right, we can say adduction. ADD, adduction. And last time we talked about two muscles that do that. Which muscles were those? Those were rhomboids, right? So rhomboids basically contract serratus anterior. It's like tug of war, right? So it's like they are pulling the rope. Okay, tug of war. The rhomboids on one side and serratus anterior on the other side. Okay, so one is pulling in one direction, the other one is pulling in the other direction. They are pulling this rope, right? So who's going to win? Protraction, okay, so that's the main function. As well, upward rotation of the scapula, okay? Well, there, as I said, it can produce downward rotation as well. It can produce some other actions as well, but he just lists the most important functions, and probably that's what we should stop. Let's not make it too complicated. Just remember protraction and upward rotation. What was upward rotation? What was upward rotation? What does that mean? Let's go to shoulder blade. I talked about that last time. I want this to be clear. Okay, so shoulder blade right there. So shoulder blade, we can either, so once again, so this is medial border. That's where the muscle starts. Well, that's sorry, it's not the correct way to say it. It's one of the muscles attachments. So that's actually going to be insertion, and in this particular case, serratus anterior, the main function is it's gonna produce this forward movement of the shoulder blade, right? So it is gonna move it towards the front. As well, upward rotation. What does that mean? So scapula can be rotated either downwards like this or upwards like that. Easiest way to remember this is that upward rotation, this is upward, this is down. Upward rotation, think about glenoid cavity, right there. This joint surface pointing up. So you're tilting the scapula up. So this the shoulder blade is tilting tilting in this direction where joint surface is going closer towards the ceiling. That's upward rotation. When the joint surface is tilting backwards, right? So going closer towards the ground, that's downward rotation. So in this particular case, two main functions of the serratus anterior is protraction. So that's moving shoulder blade towards the front, and upward rotation, right? Let's go back to the video. Like, I want to make this 100% clear. Okay. Right there. So basically protraction and upward rotation. So it's probably not that easy to say, but it's basically you're tilting that shoulder blade up like this, up. That's upward rotation. This would be downward rotation. This is upward rotation. So these are two main functions. And this muscle, basically what it does, if you know, Bruce Lee was famous for that. So 2-inch punch, right, or 1-inch punch, or whatever. So serratus anterior, if you extend the arm like this, so right there, this last movement, this last little bit of forward movement of the arm is what serratus anterior really does. Okay, and as well, it's gonna kind of rotate it upwards as well. So obviously, where would this muscle be very important? Obviously, it's going to be super important in boxing, or like some kind of martial arts stuff, because it's that muscle which does the punch, right? So it's that little bit like the last moment of the punch, right? So that quick protraction of the shoulder blade, and it's really important. Like, let's say, for example, in boxing. I think this is probably enough. We'll probably stop here. Edgar, turn your mic on. All this got to go already. So let's do a quick chat. Let's do a quick review and let's go. That's it. This is going to be probably good enough. So we talked about the levator scapula. We talked about serratus anterior landmarks. We'll leave pectorals minor, pectorals major for next time, and probably some other structures. But this is already quite a bit. We have let's quickly go back to screen share. But Edgar, so you can talk, and we can talk about it a little bit. Sorry. Okay, right there. So these are the muscles that we discussed so far. Okay, so from the front we have pectorals, pectorals major, pectorals minor, serratus anterior. That's the one that we talked just a moment ago. That's deltoid. We talked about that one as well. Trapezius, we did discuss this last time. Then rhomboids, right? Okay, actually, you know what? Let's remove all these. Let's remove all these structures, and then you'll clearly see what's happening here. Right there. This is so good. Right there. See, this is rhomboid and serratus anterior. See how they pull on each other? They're basically playing like a tug of war. Serratus anterior pulling shoulder blade towards the front, rhomboids pulling it backwards, right? And there are going to be a lot of muscles that do these motions, like kind of like opposing motions. So those are called antagonists. They're going to produce just the opposite work. So serratus anterior is pulling structure towards the front, rhomboids pulling it backwards. Let's go back. The other structures we talked about were latissimus dorsi. Yeah, we talked about that as well. And of course, sits muscles. Spent quite a bit of time talking about these guys. Supraspinatus, infraspinatus, teres minor, subscapularis, teres major, and latissimus dorsi. These two guys, they are very powerful internal rotators. Very powerful. Okay, so I think we'll stop here. That's good. Edgar's, any questions? Anything to add?
Yeah, no, I think no questions. Everything was totally clear, I think. Very good, understandable, well understandable.
Mm-hmm. Good. Well, yeah. I mean, it's not. Sometimes, like I'm just thinking, what exactly should I talk about? So sometimes I get a little kind of ahead of myself. I probably have to do these lectures a little bit more systematical, kind of, you know, like maybe I had to put like a specific plan, a little bit more organized plan, which structures, what order and all that, because I just, you know, I have something in my mind, I want to tell a story or something, and that's where I go. So I think, you know, like we'll probably improve this process as well, but yeah, you know, like this is probably the capacity that we can probably do. As for now, we can maybe do 2, 3, 4 muscles maximum. You know, that's probably the maximum that we can do during one session. So, you know, like one and a half hours to 2 hours. So it's gonna be like, you know, 90 to 120 minutes, something like that. It's just like if we go more, that's just, I mean, there's no use. You're probably not gonna remember that, first of all, and you know, I want you guys to remember this, like at least these bony landmarks. That's so significant if we're talking about anatomy. So like, let's say this external protuberance, and we talked about that. I mean, I mentioned it quite a few times, and you know, like, and still somehow, you know, it's not easy to remember, I guess, you know. You just have to put some effort in it. Like right there, external occipital protuberance, one of the most significant landmarks. We just have to remember for sure. Here we can actually, let's zoom in a bit. And here we can see those nuchal lines right there, superior nuchal line, inferior nuchal line right there. And obviously, like every bump, every ridge, everything, every little protuberance on the bone means that something does attach to it, because that's really what's happening. That muscle attachment, when we were first born, when we were babies, right? All this was more like a cartilage. It was not like really a bone. So then these first like ossification like centers start to happen. Then the bone becomes more like bone, and then we have these muscle attachments. When we start to use these muscles, those muscles start to pull on that cartilaginous structure, and the more we pull it, the more it will grow outwards. And that's actually how all these bumps are formed. You know, the more you pull on those structures, the more they grow. And you know, like for example, some like weight lifters, I mean, like their upper limbs, you know, like let's say for example, deltoid tuberosity. Like we cannot really see here, like right there, this bump here, that's deltoid tuberosity. The deltoid tuberosity is like really big. It's like for farmers, farm workers, or you know, weight lifters, that deltoid tuberosity is going to be like 2-3 times bigger than like just like a regular normal person. Like for example, Edgar's, you're running, okay? So your like legs, your lower limbs, for example, Achilles tendon, is gonna look different than from like somebody else, like different like from a regular person. All these ligaments, right? So all these other structures, they're just gonna be tough, more tough, tighter muscles in like the leg region, tighter muscles in thigh region. I mean that, like, I mean, again, it depends, you know, like if there was some kind of injury, like let's say some kind of twisted ankle or something, you know, ankle can be actually prone for luxation. Those structures can be actually more outstretched and more tight. You know, there are different possibilities there. But I mean, you know, this is how I want to talk about this. I'm teaching you guys anatomy, and then I'm giving examples from real life, from for like, you know, for sports, what type of injuries are possible, what can we prevent, how can we deal with it, how can we, I mean, teach others not to get these injuries, or you know, anything related to that. Okay, I think that's enough. That's good. It was very good session. Thank you, guys. Yeah, I'll upload this on YouTube, and then I'll probably make a couple more new videos, and I think my laptop is going to be fine now, and we'll continue. Okay, thank you, Edgar. Thank you. I'll see you soon.
Bye.
Thanks.